Welcome to everyone. Good morning. I'm Dr. Jabbar from University of Malaysia Sabah. As I only have 15 minutes talk, this talk also involves a lot of things I want to convey. So, uh, don't worry if you can't catch up with the speed and you want to understand more. Actually, I already recorded my talk in a bit slower pace in my YouTube channel. So I not right now I only have 222 subscribers. So this is the QR code for the link. And don't forget to like and subscribe as my aim is to get 1,000 subscribers. All right. Uh, Maybe this is the only slide you need to take picture. Okay. So I will start my talk. In the University of Malaysia Sabah, we're going to have our first teaching hospital in the university, first teaching university hospital in Borneo. Okay, so will be officially open in 2025, and it's a 400 plus bedded smart hospital and expandable to 48 400 beds. Okay, so we have in the planning, we're gonna have 25 operating theaters and 34 ICU beds. So why I'm saying this, because when we go towards the future in anesthesia field, more and more surgeries will be done as daycare. We know we want to be in daycare if we're gonna have surgery. So we want to recover faster. We want to go back home faster. We don't want to see all the doctors and nurses in the hospital. Okay. So 5 out of 25 OTs will be daycare OT. That's about 20% of the whole 1 out of 5. So it's about 20% of the OT will be daycare surgery, daycare anesthesia. Okay, so if you're interested, the opening is open all year long. You can send in your CV to work with us in Sabah, right? Okay, so I will start the talk proper. This talk is based mainly in the review article and also the suggestion from SAMBA, Society for Ambulatory Anaesthesia. So I'm gonna explain daycare anesthesia into 4 quadrants. One is type of facility, patient comorbidity, surgical procedure, and social factors. This is how you select patient for daycare anesthesia. So because when we are building the hospital, at the same time we are building policy and also guidelines for our own hospital. So this is how I go about it. So when we talk about social factors and surgical procedures, it mainly involve about the speed of conducting the work process, and also we always be aware of the time needed, and also we want to place safety as the main priority, and we also want to be very efficient when we are doing our work. Okay, so we talk about type of facility and social factor first. Type of facility, there are two types of daycare center. One is daycare surgery center within the hospital environment. Another is independent daycare not connected to any hospital. Okay, so the difference between the two is how much risk tolerance that we are able to take for managing this patient. So for daycare surgery involving in the physical hospital environment, we can do more complex surgery if possible. And then for independent daycare, not connected to an hospital, we only can do low risk procedures. Okay, so then the high risk patient can qualify for daycare surgery in the daycare surgery center, which is connected to the physical hospital environment. So because we hospital will have a blood bank, other specialties consult, diagnostic laboratory, and we can admit the patient for unexpected admission post surgery. Okay. So it's also there's also different between the operation hours. Daycare connected to the hospital have longer operating hours, so you can do longer surgery. For independent daycare, usually they are shorter, so you can do shorter surgery and less complicated and low risk procedures only. So it's also involved the length of surgery. This will affect the type of patient you can select because it affect the type of surgery you can do. Okay, and then, of course, as you all know, social factors is very important. You need to have patient need to have availability of responsible individual. And from studies, we know that not just any individual, the individual must be very good in health literacy of the designated individual. And also, we need to know where the location of patient's home and living condition suitability for post-surgery care. So this in turn will affect complexity of post-op orders, will affect the choice of surgery that you want to do in your daycare center, and then will affect the type of patient that you want to select for doing daycare surgery. Okay, and as well, when you talk about time, it also need to be accessible to the patient, and also need to be patient. The location must be very near, and speed of the patient to return hospital in case any problem happens. Okay. All right. So we talk about then about the surgical procedure. So the surgical procedure in affecting the patient selection is the surgery and the surgeon itself. Of course, we all like to have a skillful surgeon. So the more skillful the surgeon, the shorter the duration of the surgery, the faster you can do, the more case you can do. So you can do in the daycare surgery. So the surgery, you need to be minimally invasive. Invasive or surgical procedure will affect the choice of surgery that you want to do in your daycare center. Hence, the patient that you want to select for the daycare. So you need to be ability to control post-op pain. So all this is there any need for special post-op parenteral therapy, potential significant blood loss, and expected length of surgery? So all these four criteria will determine the likelihood of needing admission post-operatively, unexpected admission. Of course, when we do the surgery, we don't want the patient to be admitted to the hospital. Okay, so the surgeon factor also will affect the potential significant blood loss and also the expected length of surgery. So this will in turn, the surgeon itself will also in turn affect the patient selection that you want. So this need a collaboration, multidisciplinary collaboration and discussion with the surgeons. Okay, so this determines stability of the surgery and thus the patient. And also, when you talk about efficiency, you need efficient perioperative work process to ensure better outcome. Okay, so we talk about patient comorbidity. So this is the main bulk of the talk. So then I divided into age, ASA physical status, and all the relevant commodities, and malignant hyperthermia and chronic pain or opioid use disorder. So Society of Ambulatory Anesthesia said, so actually for patient with malignant hyperthermia, it is safe and it is actually, you can do uh, daycare surgery, daycare anesthesia for them as long as you use non-triggering anesthetics. So the other like dantrolene availability, the how to approach patient. This is you need to have anyway in daycare or any elective surgery. You need to have anyway. Okay, for the dantrolene. So you can do patient with history of malignant hyperthermia, but just use the non-triggering anesthetic like propofol. Okay, so patient with chronic pain, you need to involve input from pain specialist, continue the baseline opioid equivalent, plus or minus local or regional anesthesia, and you need to have user precaution in patient on methadone. Okay, so then we talk about age. Age limits, patient older than 75 years old and children less than 6 months should not be selected. Was from the early 2012 MOH guideline protocol for decade anesthesia. The recent one, 2017, MOH said, MOH of Malaysia said 6 months to 75 years old can be done in decade anesthesia. But patient more than 75 years old and less than 6 months may be considered on a case-to-case basis. Okay, so even then, the 6 months to 75 years old is actually a very wide range of age. So you need to actually alter the suitability of patient to your center, whether your center can able to handle a small child, whether you have pediatric anesthetists or not, whether you can handle geriatric patient or not, and also there must be an appropriate caregiver for you to be able to handle very young or very old patient. Okay, when you talk about age, post complication when doing daycare surgery increase when very old, more than 80 years old. Otherwise, age number should not be the only consideration. You need to improve in selection and optimization that will improve outcome. So if we select our patient better in the elderly patient or in the young patient, it will actually improve the outcomes. So we need to assess for frailty and functional capacity. Those of you who attended the previous talk from me, so you will know how important is frailty is, and then you need to assess for that. You can use clinical frailty scale, the easiest or the more specific one, Edmonton frailty scale, but it's more difficult. And then you need to do comprehensive geriatric assessment needed if elderly and frail. So this was the summary from the previous talk. Okay, you can also access this on your YouTube channel. All right. So next one, I will talk about the ASA physical status. So ASA physical status affect the outcome when the patient going for ambulatory surgery. Okay, so the ASA 1 and 2 we can do. In the previous 2012 guideline, in emerge guideline, they say only ASA 1 and 2. But in the 2017 guideline, they say we can do up to ASA 3 if the patient is suitable. So we look at this 2 million study retrospective registry database study. So it has been shown that there is a significant increase in poor outcome with higher ASA. So if you go from ASA 2, 3, and 4, you can see the graph, right? It goes up exponentially. So the post-operative complication. So this is even more significant in lab chole, lab appendectomy, and inguinal hernia in this study. So in between ASA 3 and ASA 4, the mortality odds ratio is increasing according to regional anesthesia, MSA sedation, and general anesthesia. So the more higher ASA that you want to do in ambulatory surgery in your daycare center, you need to be thinking of what are the more suitable technique that you want to employ for anesthesia for the patient. Okay. All right. So now in the 2017 guideline, emergency guideline, you can do ASA3 provided the comorbidities are optimized. So in IARS Society guideline, so optimize comorbidities in ASA3 and ASA4 only simple LA based procedures and cataract surgery. But mind you, if you look at the long term study of cataract in ASA4, actually the outcome is not very good. Post-operative outcome can go up to 40 to 50% as well. Okay. All right. So next, this is one of the most quoted study when you talk about ASA3 in daycare surgery. So this is why the KKM added the ASA3 can be done so long as the comorbidity is being tackled. So no difference between ASA1 or 2 versus ASA3 in terms of admission to post-op daycare surgery. Around 1.9 to 2, 3.6%. Drowsiness, nausea, bleeding, and pain is the same. So it's actually okay for ASA3 so long as the comorbidity have been tackled. So, okay, among the important factor is the TIA or stroke. Having previous TIA or stroke, this is a subgroup of patient with among highest risk for post-op complication specific for ambulatory surgery and also elective surgery. So MACE, the adverse cardiac event, major adverse cardiac event in this is a Danish cohort 500,000 patient study. So from the onset of TIA, only TIA or stroke, as you go on after the TIA or stroke, the odds ratio for mortality is very high in the first 3 months, about 14.23 times higher than the normal individual, and then 4.85, 3.04, and 2.47. So indeed, actually, even after 1 year, the odds ratio to die it remain elevated more than 2 times compared to the normal surgical population, those who do not have TIA or stroke. So you need to be very, very careful in choosing the patient, like for TIA and stroke, for to undergo daycare surgery. So in this recommendation from this study, they recommend that you need to postpone up to 9 months after the post TIA or stroke. Even if you postpone after 9 months, 1 year, 2 years, 3 years, it doesn't the risk is remain elevated, 2 points, almost 2.5 times higher than normal population. But the risk are already stabilized. It comes down and stabilized 2 times higher. Okay. All right. So antiplatelet therapy in this patient, you need to do comprehensive individual risk benefit assessment. Okay. So obesity specific anesthesia risk, as you all know. Okay. And also obesity have related comorbidities. Of course, when you have obese patient, you need to optimize all the comorbidities. But there are certain highly contraindicated patients that you may not choose for surgery in obesity patient for daycare surgery. This is obesity hypoventilation syndrome, as they have increased sensitivity to opioid and anesthetic agent. They also recover late, and they also prove to be have more complication in when they have OHS. Okay, so you may also not choose severe pulmonary hypertension, severe coronary artery disease, and heart failure in this type of patient, in obese patient going for daycare surgery. So obesity, any BMI cut off. Okay, so I'm also obese myself. So what a BMI cut off? So I'm also scared that I cannot go for daycare surgery. So the old 2012 MOH daycare protocol mentioned BMI less than 35. So if it's this been the case, I'll be already dropped out of the daycare surgery. So I'm no longer a potential patient anymore. But the evidences available are not enough yet to suggest. So all these QR code that you're seeing is the references that you want to, if you want to have a look at. Evidence available not enough yet to suggest any BMI cutoff. But BMI cutoff, if you see the ASA qualification, is actually equivalent to ASA 3, ASA more than BMI more than 40. So there's a systematic review conducted in 2012 and 2016 by the same group, Joshi group, concluded that you may need to think about not doing super morbid obese BMI more than 50 in daycare surgery. Even then, there is no real evidence saying it is increased post-operative outcome, bad outcome lah. But you may think of not choosing them lah more than 50. Definitely, you need to tailor to your capability. You need to know need to have an insight on what patient that you want to do and you can do. All right. So in this study, early postoperative outcome in obese patient. So actually, as I told you, in this very big study from 600,000 patients, they do case control propensity match. They match between BMI 40 to 50 and BMI more than 50. Actually, there's no difference. Okay, so there is not enough data. It can suggest what BMI cutoff is the good one. So when there is no good evidence, what do you want to do? You need to ask yourself, how much are you comfortable with in managing the obese patient in daycare surgery? So next, cardiac disease, hypertension, AAGBI said less than 180 over 110 is a reasonable target. You need to cancel or delay symptomatic or acute and organ damage. You need to do those very low risk of MACE in coronary artery disease. Of course, when patient having heart failure, they have a very high mortality risk, and especially in those with LVEF less than 55%. You need to optimize them before they come for daycare and only do in daycare tertiary center only. You need to be cautious in severe stenotic lesion and only allow surgery, low risk surgery, and only in tertiary center. For AF, new onset and symptomatic AF complicated. Sorry, that's a typo, not A. One typo is very much different. New onset and symptomatic AF is contraindicated for daycare surgery. And chronic optimization you can do, but you need to think about the bridging anticoagulation case to case basis. Coronary artery stent need to balance risk of bleeding and risk of stent thrombosis. Okay. All right. So for SA, stock bank is the best tool that we have now. Avoid daycare surgery in optimized comorbidities and don't have OHS, and you need to use opiate-free and sparing approach. So if you look at this suggestion that you can see even if the patient not on CPAP, even if the patient refuse to use CPAP, you can actually safely manage them. Okay, so long that you avoid opioid in your daycare surgery. Okay, you know a lot of things that you can do to do opioid free, regional anesthetic, NSAIDs, COX-2 and so on. Okay, alright. Alright, so COPD, you need to avoid in very severe cases, and if you have a severe disease, you need to do FEV lung function test, FEV1 less than 0.75, not suitable for daycare. And stage renal failure, they are safe to undergo daycare surgery, but you need to have a little bit more higher risk tolerance for anemia, cardiac ischemia, asymptomatic mild hyperkalemia. So don't to be too fussy about the numbers, okay? Because it's actually quite safe. So in a study done by Rao in 512 patients shown in post-op complication, actually, uh, majority of cases are safe, and only those with heart failure and prior cardiac surgery in cerebral failure with higher complication. AVF creation was proven to be safer, lower complication is more preferable by the patient when you use LA or regional anesthesia compared to general anesthesia. And actually, patient prefer and lower complication if you do as outpatient surgery. So in this study, they compare daycare surgery versus elective surgery. So 3 times lower readmission in daycare surgery compared to inpatient surgeries, readmission after they discharge. So it's actually better to do if you're doing under LA or regional anesthesia, you need to do the AVF under daycare surgery. All right. So take home message, take the home, take home. So you need to balance between risk and benefit. So patient selection. So remember the 4 quadrant social factors because it involves about immediate early post-op care and management. And then you need to think a lot about time. Okay, because you need to ensure your technique, your rapidity of onset of anesthesia technique, offset to anesthesia and complication. Regional anesthesia technique may help. And you need to think about type of severity in patient community, complexity of patient with their innate risk, and then you need to about surgical procedures, complexity of surgery, and able to perform in your ambulatory center. Of course, when you have a daycare surgery which is efficient and speed, patient and the surgeon will be satisfied. Okay, but only when we achieve a good safe outcome for the patient, only then will anesthesiologists like us will be satisfied. With that, thank you. Thank you, Dr. Gagan. May we be creating the physical